We've been using the TPOs for 10 years or just over 10 years. And these new drugs, these were the first really fully approved drugs that were designed for ITP. And they've been amazing drugs. They have very high efficacy. And there's a brand new one that has been launched called avatrombopag, which I discussed in my talk. But we need more than one type of treatment for any disease, and ITP is no different. We cannot rely on one type of therapy. But luckily, going through clinical trials, we've got 3 or 4 new types of drug. For example, we have the anti-neonatal FC receptor drugs being developed, and they look very promising. We have the Bruton tyrosine kinase inhibitors also, and again, the data from the early studies look very promising. We have anti-complement drugs, which again have shown some promise, and 1 or 2 other classes of therapy, early stage of development, but that doesn't matter. I think within 5 years or so, we will have around 4 to 6 classes of therapy for ITP. 1 will be TPOs, 1 will be neonatal FC receptors, 1 will be BTK inhibitors, 1 will be complement, 1 may be other, I don't know, anti-CD38s or something else. So we'll have about 6 different types of drug. So if a patient fails to respond to all of the TPOs, we will, of course, try one TPO, then another. But if a patient does not respond and yet still needs something, then we can use one of the new classes of drugs coming through also. And the other thing, which I didn't mention in my answer, of course, is we have fostamatinib, which is a Syk inhibitor, which has been relatively recently launched as well. So we will definitely have around 6 classes of treatment.